So let's get started. So little introductions from each of us. I'll start with myself. My name is Mike Hutchins. I am the co-founder of ACT Leadership, and just a little bit about my background. So I'm a professionally certified coach, and I have 25 years of consulting and leadership development experience working with the big four accounting firms, doing global transformation work. Our company is based in Washington, D.C. We do both federal and non-federal business. In the federal side, we're currently putting 800 senior federal leaders through our leadership coaching program. We also work with Brown University, collaborating with them on this leadership and performance coaching program. And we provide the executive coaching and the coach training to their executive MBA programs. I'm delighted to be joined today by two of ACT's partners, starting with Helen Roberts. Helen, if you'd like to introduce yourself.
Thanks, Mike. My name's Helen Roberts. I am a coach, a professional certified coach, but more relevant to this call, I've been coaching and consulting in healthcare for 18 years and organizational development for 25 plus years. The kind of people that I've coached are senior management, managers, physicians, and staff to address the problems they experience in day-to-day. I also help design and deliver the senior management, middle management, and frontline management training programs for healthcare in the province of British Columbia.
Great, thanks, Helen. And we're also joined by Dan Hollingshead.
Yeah, thanks, Mike. And hello, everyone. It's great to be with you all today. Just a little bit about myself. First, I am a graduate of the ACT Leadership and Performance Coaching Program, and I certainly can tell you firsthand it was amazing and transformational for me, both personally and professionally, as these new skills that I learned in the program have been super helpful to me in my healthcare consulting work that I've been doing recently, primarily with physician groups. But to back up just a bit, I started my career in healthcare some 26 years ago as a clinical perfusionist, which is the person that runs the heart-lung machine during bypass or major organ transplant surgery. So I was clinical for about 10 years and was a chief most of those years. So I personally performed several thousand procedures, including very complex neonatal congenital repairs even. After getting my MBA, I became a vice president of operations for two really large healthcare services companies, and that timeline takes us up to about 2007. Since then, I started and still run today a healthcare software company called Connected Patients that helps hospitals and other healthcare facilities to, in real time, measure and improve their patient experiences. And then for the past few years, as I mentioned, first thing, been doing some healthcare consulting, and now have included coaching into that and those skills. So, and then lastly, I'm joining you all from horse country, Lexington, Kentucky. And that's, I think, quite enough about me. Mike?
Great, thank you, Dan. So just a quick overview of this session. So we're going to start out, I'm just going to give you some introduction around why the coach approach, why now is coaching so topical, and what is it you can learn from the coaching profession. And then Dan's going to pick up on really focusing on how we've split this into 4 stakeholder groups for this call.
Yeah, so just given the amount of time that we have today, we thought we'd focus on the 4 key stakeholder groups and the interactions that these groups would routinely have in virtually any healthcare setting, whether we're talking acute inpatient or outpatient or an office setting even, or practically any healthcare setting. So of course, there are many more stakeholders than these four, but for the purposes of the call today, let's focus on the patient, the provider, the leader, and administrator. So what we see in healthcare facilities or entities generally that have very good communication between these stakeholder groups, they're successful. And whereas it's also pretty easily trackable or traceable within organizations that are less successful, that they have broken relationships and poor communications between these groups. So I'm ready to get started. Mike?
Good. And for each of these four stakeholder groups, we're really going to structure the presentation with, what are some of the challenges that we see facing these groups? And then, we'll talk, and Helen's mainly going to talk about sort of anecdotally the coach approach that she's used and the results that she's got from applying the coach approach. And then we're going to talk, so that should take us to around 12:30, 12:35. And then we're going to talk, we'll introduce our spring leadership and performance coaching program. We'll talk a little bit about that, that ACT is running in collaboration with Brown University. And then any questions that you have, we'll answer at the end. So let's just get clear and crisp on our definition. What is it we're calling leadership coaching? So we'll start with the International Coaching Federation definition, which is partnering with coachees in a thought-provoking and creative process that inspire them to maximize their potential. So it's really looking at, what are the gifts or the skills that a coach has, their ability to create that deep focus and connection with the other person, the ability to read situations more deeply, really understanding what motivates people, having them connected to their values and their purpose, creating that authentic, safe environment where there's that trust to have difficult conversations, such as giving feedback in the moment to somebody in service of their development. And the other key component of coaching is really withholding giving advice. So it's the idea that you will develop the other person by allowing them to find the answers for themselves. So it's really that ability to know when to step in and take charge, and when to pull back, rein back, and sort of allow that other person to grow and develop, so that they can really think it through for themselves. The coaching industry is flourishing at the moment. What we see from surveys that we've done is that, leaders don't always have the answers. Millennial or next generation, are certainly resisting orders or traditional styles of leadership. Dynamic relationships are constantly shifting, and there's really just greater pressure for results. So coaching, or being coach-like, really empowers and develops the workforce and allows people to grow and express what's important to them. So you'll see here, we've just taken a few of the coaching skills and concepts that we use in our program. And we're going to walk through in this presentation how they've been applied in different healthcare contexts. I'll talk just a little bit about a few of these. So the idea of, on that first graphic, that we call it our compass, but it really is, if you imagine it, we want our people to be operating above the line all the time. So we explore with the leaders, whether it's one-on-one coaching or through 360s, like what is it that triggers them to become reactive? And by reactive, we mean having a low level of self-awareness, not aware of the unintended impact that they're having on people around them. So how do you build more awareness so that they can then recover back, and work from what we call creative place, where they are responsible for their emotions, they are responsible for the impact they're having on the people around them. And then the other challenge is, how can you keep people in authentic relationships and also achieve results? So we appreciate that, especially in a hospital environment or in healthcare, there's the constant need, whether it's financial or patient, whatever it is, there's that need to be constantly achieving results. The other area we're really going to focusing on is designing the relationship. So, when we think about these four stakeholder groups as different relationships, we ask the question, what does a successful relationship need to look like? If we take a physician and a nurse, Often the nurse has valuable patient insights, but maybe feels intimidated to speak up. So how do they respect the need for the clinical hierarchies, but really create these sort of dynamic protocols that facilitate that effective communication? What does the relationship really need to look like for us to succeed and ultimately provide, great patient care and experience? And then a number of the skills we'll look at, active listening, being able to use, listening for the facts, the information, but also listening on an emotional level, really using metaphors to translate complex technical information or jargon into something that is very palatable and easy for someone to understand, using different questioning styles, and really just being able to create that safety and trust so that people open up and share more. So those are kind of the areas that we're going to focus on. These are some of the skills that you're going to see applied through the rest of this presentation. So I'm going to hand it back over to Dan, who's going to introduce the first stakeholder group.
Right. Thanks, Mike. So yeah, let's get right into the meat of today's webinar. Provider to patient is our first stakeholder interaction group. And this really is the most important of the relationships we'll be discussing today, even without layering on the concerns of something like, say, value-based purchasing metrics that can have a huge effect on your facility's reimbursement and overall health, financial health, certainly. This relationship, I think, for all of us on the call is our why. Why we went into medicine as our particular path to serve others. And it's important because it is this relationship that speaks most directly then to our values. But what happens when the external factors of our jobs, the environment that we work in, let's say, and even in our own lives, it can cloud our own view of our value system. And so then in this situation, it's easy to fall into some of the patterns that we describe here, where very little attention is paid to the patient as a person, and a person who, frankly, is infirmed. They're in a strange environment. They're probably scared, and they need to trust a bunch of other strangers to help them heal and feel better. But remember, we're rushed, right? We have too much work and too little time, and so we're in a reactive state, and so what happens is we fail to really sense into what's happening from the patient's point of view. And of course we don't need to do that, but we use words that are too big and not well understood outside of medicine, this medicalese that we've noted above, and it all adds up to a most important relationship that is frankly not optimized, and thus the same goes for the care of the patient. And so coaching and being coach-like during these times, especially using what we would call level 3 listening and asking powerful questions, and also like recovering quickly from that reactive state back to a creative state, can help make all the difference. And so, Helen, would you mind sharing a great example that you have for everyone?
Sure, I'm happy to do that. And before I do that, I want to mention one thing. I am calling from Fiji, and a couple of times the phone has gone dead for me. So should that happen, Mike will pick up with my example. So I just wanted to give you a little bit of a heads up there. So back to the idea of the patient being lost and scared, and the idea of no time. So I worked with 2 different physician groups in British Columbia. One was an acute hospital with the cardiology, nephrology, and pulmonary departments, in addition to working with GPs and patient reps, and another group with just nephrologists across the whole province, and patients and GPs. And what my job was to coach those 2 groups to come up with an idea of what it was they wanted to work on to improve patient communication. And what I found most interesting was that through the questions like, what's most important for your patients, what's getting in the way, what would be a significant action you could undertake, what happened was the 2 groups came up with the response that they wanted to work directly with the patients in asking open-ended questions, and they wanted, they both came up with very, very similar questions that they wanted themselves and the physicians to respond to. The questions were things like, what brought you here today, which would allow the patient to drive the agenda. What are you most worried about, which would help them get at the fears and concerns that people brought. And what are the changes you will make? And ensuring they have a plan that they own before they leave the office. So I left the organization before the changes were fully implemented, but I was there during the whole pilot process. So the physicians that I was working with put these questions to their patients in their offices, and they reported that because of this curiosity that they were exhibiting, they felt they were more able to get quickly to the heart of the matter. The questions didn't take much more time than doing it their old way, which was, I know, a huge issue in healthcare. And also that they had immediately a greater sense of trust and connection with their patients. And what was also interesting was they had more compliance. And fundamentally, at the end of the day, the physicians felt that they'd done a better job. So that's an example that I came up with around the provider patient. So back over to you, Dan.
Great.
Great.
Yeah.
Okay. So leader to staff. Now, leader in this context, it could be a nursing supervisor or a hospital administrator. It could be an office manager, or maybe it's a physician leader. But you know, the challenges, frankly, for these different leaders can oftentimes look more the same than different. So things like personalities within the team, or mistrust of one functional area of another, you know, these all essentially can cause breakdowns in what would otherwise be a highly efficient and effective care team and or, you know, facility. So these challenges, bit by bit, they drive up the cost of care because they tend to slow down the delivery of the care and muddy those clear pathways for care delivery. And might I add, you know, it usually will drive down the experience of the care, you know, for both the patients and the caregivers themselves. So, and of course, it's very likely to have a negative effect on the overall quality of care. So here again, coaching skills can really help leaders to be much more present and to sense into situations more effectively, and apply these learned communication skills to open up the communication versus shutting it down, which, you know, when we become reactive is typically what happens. And then this allows for a much greater understanding of the other and alignment within and between the team. So here again, Helen has an example to share with us. All right. I don't know. Have we lost Helen?
Oh. Okay.
Oh,
Can you hear me now? Sorry,
gotcha.
I've been talking away. Okay. So eating disorders team that I worked with, we had problems at two levels: the leaders to the staff and the leaders to the themselves. So between the groups. So it was a triumvirate that led the team: a physician who also worked in the emergency department, a researcher physician, and a administrator. And so this team had trouble for about 20 years. So I know that for a fact because I worked with them when I very first started working in healthcare, and nothing had worked. So this time we decided to take a coach approach. And first of all, I started with the coaching one-on-one with the admin leader, and focused on her values and purpose and what she saw that was getting in the way. And what we realized in that process was that she saw things in black and white, and as a result, often sided with the administration against her team, which obviously didn't go all that well. And so with that awareness, she kind of softened her approach and became less judgmental. And I started working with the leadership team. From there, I coached the three of them to have a very difficult conversation. There were some super hot issues. They were frustrated. Two of them were frustrated with the physician leader, who they felt was absent very often. The researcher felt they were discounted, which is something I understand that many researchers feel. And the leader felt demonized. And so the three of them had this difficult conversation where they were encouraged to really listen actively with one another. And they ended up redesigning their relationship. And for the first time, they agreed that they were going to act as one, as if it was one leader speaking. And that was the point where we decided we could work with the team. And with team coaching, I ask questions like, what is needed in your environment to make it successful? What's getting in the way? What do you need to do differently? And as a result, the team decided to redesign their relationships with each other and with the leadership. They developed some simple rules, and then that they were going to follow, and then they just surveyed regularly, and the researcher did all the surveying to make sure that they were staying on track. I coached the leaders to take over my role as coach, and also the admin leader went on to take further coaching skills so that they could keep the process going. The team has actually come together so well that as a result of being clearer on their purpose and how they want to work together and their blind spots, that they're now able to resolve conflict so much more effectively than they ever have been. And I think the icing on the cake to me was I got a call about 2 months ago from another team that wants to copy what they've done because they've been so successful. So I think that gives a pretty clear picture of how coaching can help in a stuck team. Okay, thanks a lot. Over to you, Dan.
Great, thanks, Helen. So moving on to provider to provider. So here, you know, one of the things that can get in the way is the hierarchies that exist within the healthcare vertical. And, you know, historically, of course, they exist in medicine on a very high level to keep the patient safe, right? So it's the MDs that are making the medical decisions because they went to medical school and have the most, you know, clinical knowledge, et cetera. But, you know, today, what we're seeing for a whole host of reasons is that, you know, that hierarchical model is overly simplistic. And what's happening is it's getting stressed or challenged by what we generally see, I think all of us on this call, I bet, today as a real need in today's modern healthcare environment, where teams and team-based care are necessary, right? Absolutely necessary, because frankly they are better able. We've shown many times to generate the clinical and experiential results that are expected. And I can tell you, you know, in some very recent coaching and consulting I've done, that it's you know, not surprising, I'm sure, to most, that some of these old paradigms of hierarchy, you know, even among physicians and physician groups, they still exist. You know, in my case, I was recently working with a cardiology group and a hospitalist group, and the struggles between the two, where, you know, they just were not able to align their needs with each other, and so what was really lacking between the two of them and creating that struggle was impact, right? So namely, what impact do I intend to have versus the impact that I'm actually having? And it was creating a lot of strife and misalignment. So I think, again, Helen, if you could share with the group another example that you have.
Sure. This one happened as a result of a 360. This individual got some feedback on his performance that his anger and the fact that he was pretty high up in the hierarchy was really having a major impact on the way that he related to his peers across the organization, and the people that he reported to. So I worked with him on a whole bunch for quite a long time on a whole different variety of ways to address the anger. And we used, I used a lot of active listening, curiosity, open questions, and metaphor. We talk about metaphor, and I think it's important that I just give you an example of what I mean by that. So in this case, his anger for him, every time he was a director of HIV, AIDS, and addiction, and he was huge. His purpose was all around. It was all about speaking up for the underdog. Every time somebody did something which impacted his client group, he went ballistic. And the metaphor for him was a volcano. So using that metaphor and unpacking it, we discovered that, you know, his impact, he got a really visceral insight into the impact that he was having on other people. And through that, it helped him step into leadership in a different way, where his empathy for his clients was extended to the empathy for the people that he worked with. He became more curious and empathetic about them, and fundamentally shifted the way that he operated. He now has much greater emotional intelligence when it comes to working with his peers. He's much more curious about them and much less judgmental, and is actually now looked upon as a truth teller in the organization. So back over to you, Dan.
Wow, amazing. Yeah. And then the last stakeholder interaction group we'll talk about today is provider to administrator. So obviously super important to the healthcare, to the health and success rather of pretty much any healthcare organization, and yet is very often fraught with challenges of, say, perceived misalignment of goals, misinterpretation of the actions of the other, disagreement around how best to organize and mobilize the organization's resources, just to name a few. Or perhaps it's the challenge, you know, that we have listed above, where an MD really, you know, wants to change the way things are done clinically for the better, but is stymied by the complexity of the system and the politics and all of that. So in my experience, especially here between these groups, I've seen where skillful use of coaching and being coach-like among the members themselves can really help for them to stay in a creative mindset more often, which as you learn more about that, you'll come to know that it naturally supports the values and the talents of everyone. So the end result being dramatically improved team effectiveness and morale, both. So anyway, Helen, would you mind sharing with us another example for this group?
Yeah. Sorry, I'm a little bit disconcerted because you disappeared there for a minute, but you're back. We have the group I was working with was, well, actually, sorry, the leader I was working with was an elder care physician leader, and she was responsible for 4 elder care sites through the Lower Mainland in British Columbia. And she was really frustrated because she had was dealing with more and more complex patients. People were coming into elder care much sicker than they used to, and they were dying much more frequently. But she still wanted to implement something called the Eden Alternative, which some of you on the phone may be familiar with. But for those who aren't, it's a model where residents who live in the facilities are treated as if they're living at home, as opposed to being in an institution. So I coached this consultant and consulted with her around what was it that drives her and what's so important about this change. And from that re-clarified vision, we started to look at the stakeholders that she was working with in administration, and she reframed her thinking about them as if they were team members. And so through the coaching relationship, she talked more and more about how, she got more and more curious about what it was that was driving them and what it was that they needed. And with this reframe, she decided on a whole different approach with the administration, which started to weave the Eden alternative values with the organizational values. And again, she redesigned her relationship. So some of the battles were won. The Eden language and the behaviors became part of the environment, and they are still being reinforced today. She also learned about where she was giving away her power, and decided to only accept responsibility for what she could change, and stop working from a reactive place. And she was a lot more flexible with her leadership style and more realistic about what she could and couldn't control. So she's now viewed as one of the most admired leaders in the elder care community in the province of British Columbia. So I think that's it for me. I'm going to hand it back over to Mike.
Great, thank you, Helen and Dan. So yeah, in summary, there's certainly some themes that are starting to hear around what is it we can learn from a coach? What is it we can learn from leaders being more coach-like, applying those coaching skills and coach approach in these different work contexts? So some of the themes we're hearing is that ability to really listen empathically. So not just for the facts, the data, the information, but really listen to what's the underlying emotion. What are some of the assumptions? Whether it's a patient, whether it's staff member, what is it that's not being said? And often there's gold in that piece. So it's the ability to connect with that, the ability to read people better, create more safety and trust, so they do share more information, and they do have more authentic relationships where they can, be more efficient at really, giving it and receiving each other's feedback in the moment, so that they can have awareness of how they're showing up, make better choices, and ultimately lead to better patient care and experience. So we're going to shift now, talk a little bit about the program itself. And so the program is called Leadership and Performance Coaching Certification. And this is the program that we are running in collaboration with Brown University. We're currently running the fall program, and in the spring, we will be running it again then. So the target audience is experienced professionals, really a minimum of 5 years of experience. And the program duration is 6 months from beginning to end. It would be 9 days. You'll be 9 days on campus. The campus is at Brown University School of Professional Studies in Providence, Rhode Island. Here are the dates. So there's module 1, module 2, module 3. Each of those in-person modules is 3 days, so 9 days in total. And yeah, you see the dates at the top. So module 1 starts on the 19th of March, 2019. A little bit about, so coaching foundations really is just going through the core coaching concepts, coaching skills, looking at the difference between coaching and mentoring. And really after module 1, you will already be ready to apply what you've learned back at work. So you will already be having coaching conversations. You will already know how to be coach-like, how to ask questions differently, how to listen differently back at work. And then module 2 really goes much deeper into the coaching concepts. So we look more deeply at values and purpose. We really look at the self-limiting beliefs that people may have about themselves, so they get a better awareness of how they show up and how to reframe so that they can operate more effectively. And then module 3 is really looking at how can a leader expand their range. So how can they use different styles for different contexts? It's almost like situational leadership. How can they flex their style to whatever is needed in that moment? So they have more awareness of their presence, how they show up, how they can have greater impact and integrate. And we also look at emotions. So we really look at, how can leaders be more emotionally intelligent? How can they be more responsible for their emotions and the impact that they have at work? So they can really harness the energy and the the power of the emotion rather than it becoming reactive. So it's a 100 hours. If you're looking for it, our program is credentialed through the International Coaching Federation. If you were looking for an associate certified coach formal qualification, which is globally recognized, then you would need to get 100 hours of coaching. In our program, to complete our program, you need 24 hours of coaching practice. And there's also a bunch of virtual components to the program. There's mentor group calls, there's individual mentor calls where you will have time with an individual supervisor who will really listen to your coaching and give you feedback in the moment. Okay, so that is the program. So now going to just see if we have any questions. So just bear with us for a second. Okay, so first question is, what makes your program unique? So there's a number of elements to this. You know, one is it's highly contextualized around organizational challenges. So we really look at different leadership concepts, and we use a lot of research around what makes effective leaders, and we weave coaching into that. It's highly experiential. So, you know, you're going to be practicing, whether it's in the classroom, whether it's in your groups, you'll be doing a lot of practice and really looking at application. So how can I be coach-like, weaving it into day-to-day leadership? We look a lot at the neuroscience aspects of it. So we really, in parallel, look at, well, what's going on in the brain when you are being coach-like, or when you are giving advice, for example, what's the impact that's having on the other person versus when you're really being curious, asking them open-ended, powerful questions and having them think for themselves. So we really look at the developmental aspect of that. What else is there? Yeah, we keep it simple and we integrate early. So our program is 9 days in person. You'll see a lot of other coaching schools. They can be 12 or up to 15 days. We've really sort of focused on what's important and what has the greatest impact. So we integrate our program early. So rather than looking at things in silos, we really, in module 2, we start to integrate all the different pieces so that by module 3, you have that fluency in being able to coach using these different concepts and range of different skills, and really being able to meet whoever it is that you're coaching, understanding, like, meet them where they are and help them shift. And we really focus on, like, how do you help them shift? What else? Is this program an ICF accredited program? Yes, it is. So it's with the ACSTH path with the ICF. So once you complete our program and you get your 100 hours, you would then go onto the ICF website and you'll see our programs approved there. What else? Is this program specific to healthcare? So we have students in from, participants in from any industry. So in our current cohort, we have financial services, we have education, we have telecoms, we have device research. So we've got a whole range of different industries. We're not industry specific with this program. And one of the benefits of that is there's so much to learn from, you know, different industry experiences. How quickly can I apply these skills? So yeah, I think I answered that one. So really after module 1, you know, the idea is that you leave after module 1 and you are able to, you know, go back and apply these skills. All right, that is everything that I have here. So I'm going to hand it back now to the program coordinator for this, who will end this call. So thank you everybody for attending this call. If you do have further questions, you'll see on this page, you can email Katie at ActLeader, or if you're interested in applying, you'll see the link below. This recorded webinar will be available on our website, so if you want to listen to it again, you're welcome to do so. And yeah, that's all I have. So once again, I'd like to thank Dan and Helen for joining us on this call. Thank you for the valuable insights. And Happy holidays.